Doc, my patient is having high blood pressure. This is one of the most commonly received phone calls while covering the floor, as I mentioned in my last video, in which we discussed how to recognize and respond to a hypertensive emergency. Watch to the end. Today, I'm going to teach you how to respond to a patient with elevated blood pressure who is stable and asymptomatic otherwise. Whether you are a physician receiving this phone call or a nurse making this call, this video is going to be very helpful to you and will help you avoid unnecessary treatment. As we discussed in our last video, when a nurse calls me about a patient with high blood pressure, I reflexively ask 3 questions and I repeat them here again. What are the rest of the vital signs? Very important to know the full set of vital signs. If the nurse doesn't have them, kindly ask them to call you back with a full set of vital signs as soon as possible. Remember, heart rate, respiratory rate, temperature, and pulse oximetry. The second question is whether the patient has any concerning signs and symptoms. I explained what I mean by concerning signs and symptoms in my last video, the hypertensive emergency video. Link to that video is provided in the description field. And the third question is whether the patient is pregnant and what trimester. Of course, I only ask this if the patient is a woman of childbearing age. As we mentioned last video, if the vital signs are unstable, the patient is having concerning signs and/or symptoms, or the patient is pregnant, the patient is possibly or probably having a hypertensive emergency, leave everything and go see the patient immediately. If the rest of the vital signs are normal, the patient is asymptomatic, and the patient, of course, is not pregnant, then you can finish your bite or finish what's in your hand. There is no emergency here, and this is by far the most common scenario you will encounter while covering the floor. How to respond to such patient is the topic of our video today. When the patient is stable and asymptomatic, I add a 4th question. I ask the nurse about the patient's blood pressure trend over the previous 48 hours or whatever blood pressure values are available to compare to. Sometimes I even ask the patient about their home blood pressure readings so I can compare to. This will give us an idea if this elevated blood pressure value is a single isolated out of the trend value or not. If the blood pressure trend has been running high, then likely there is no error in the blood pressure measurement. On the other hand, suspect a blood pressure measurement error if the elevated blood pressure value was a single isolated and of course off the trend. In such a case, kindly ask them to recheck the blood pressure. If the value is still high, there is still a possibility this may be a measurement error. In general, there are 2 main sources of the non-invasive blood pressure measurement errors: inappropriate cuff size or inappropriate cuff position. Remember this, the appropriate cuff size should be 80% long and at least 40% wide of the circumference of the upper arm. Suspect a small cuff issue if the diastolic blood pressure is markedly elevated with a narrow pulse pressure. Remember, the arm is the standard place to measure the blood pressure. We should place the cuff just above the cubital fossa. The cuff should also be placed on the bare arm or over a very thin sleeve. Do not roll up the sleeve or place the cuff over a thick sleeve, please. When the arm cannot be used to measure blood pressure due to the presence of arm fistula, graft, indwelling catheter or surgery, the wrist or the leg can be used. If we use the wrist, make sure to keep the wrist at the level of the heart. Otherwise, the blood pressure may be falsely elevated if the wrist is below the heart. If we use the leg, the systolic blood pressure in the lower extremity usually higher than the brachial artery, except in peripheral arterial disease and aortic coarctation, where the pressure usually lower in the legs compared to the arm. However, overall it is very difficult to reliably translate leg pressure into arm pressures, so use it only if there is no other option or if you are checking the ankle brachial index. Now, as you probably know, there are 2 non-invasive ways to measure blood pressure: the auscultatory method, or the manual method if you want to call it, or the oscillometric method, or using the machine. Both are fairly accurate, although the oscillometric method has not been validated when checking blood pressure on the leg. Okay, now we confirm the patient is having a high blood pressure and it's accurate, it's not wrong. The patient is otherwise asymptomatic. What's next? Now, regardless of how high the blood pressure is, Two main things should be done first in all of these patients. First, as long as these patients are not in PO, they should be placed on a low sodium diet, 2 grams sodium. And second, make sure the patient's home blood pressure medication have been resumed on admission. One of the most common causes of elevated blood pressure in the hospital is not to resume the patient's home blood pressure medication when they get admitted. That's of course if the patient is not strictly in PO or there is no contraindication to give his home medications. Doing these two things can solve most of the elevated blood pressure issues in the hospital. Now, when should we consider adjusting the patient blood pressure regimen or adding a new medication? Now we look how high the blood pressure is. And here I place these patients in two categories or groups. The first group is those with systolic blood pressure less than 180 and diastolic blood pressure less than 120. Both of them has to be present. The second group is those with systolic blood pressure more than 180 and or diastolic blood pressure more than 120. The goal in both groups is to lower the systolic blood pressure to a target of less than 160 systolic and less than 100 diastolic. So how do we achieve this goal? In both groups, I place them on the 2 gram sodium diet and I make sure their home blood pressure medications are resumed. That's likely will solve the problem in the first group as there is no rush to lower their blood pressure here. Let's assume the patient was already on a low sodium diet and the correct doses of his home medication. Here, simply I will adjust his home medication or add a new long-acting agent to the patient's regimen. For the second group, the blood pressure is significantly high and we need to lower it relatively quickly. What I mean by quickly here is over a few hours, over 4 to 6 hours. And this can be achieved by giving a single dose of a short-acting agents. And we use them only to bring the blood pressure quickly down, not for long-term use. The most commonly used agents in practice are clonidine and captopril. Please do not use sublingual nifedipine at all. It's contraindicated. Clonidine 0.1 milligram PO times 1 or captopril 6.25 milligram times 1. Clonidine works faster than captopril, which may take few hours. Remember, clonidine should be avoided if the heart rate is less than 50. Clonidine also is preferred over captopril in volume overloaded patients. Adjusting the patient blood pressure regimen or adding a long-acting blood pressure medication can be done at the same time as well. What if the patient is already on clonidine? Simply, we can give an extra dose of clonidine. Now, how about a clonidine patch? A patch means a long-acting medication. That is not going to be helpful in lowering blood pressure quickly, so don't use it. Now you may be wondering, when do we use IV blood pressure medications? IV blood pressure medications should be reserved for those who are strictly in PO, or if I want to bring the pressure down much quicker. Let's say the patient is getting very nervous from the elevated blood pressure and wants his or her blood pressure to get better quickly, then I can use the IV blood pressure medication. Unlike the practice now that everybody jump to those IV blood pressure medication in a lot of cases. Now the most commonly used IV medications in practice are labetalol, hydralazine, or enalaprilate. 20 mg of IV labetalol push, 10 mg of IV hydralazine, or 1.25 mg of IV enalaprilate. Labetalol should be avoided if heart rate less than 50. Remember, hydralazine can cause reflex tachycardia in the low hundreds, and enalaprilate to be avoided if allergy to ACE inhibitors, hyperkalemia, or acute kidney injury. We usually ask the patient's nurse to check the blood pressure within 4 to 6 hours if oral agents are used, or within an hour if an IV agent is used. If the blood pressure is still above the target, we simply can give another dose of the same medication, or increase its dose, or pick another class if there was no response at all. Let's say a patient blood pressure was 190 over 100. We gave 0.1 milligram of clonidine, and after 4 hours the blood pressure was 180 over 100. Here we can give another 0.1 milligram of clonidine, or increase the dose to 0.2 or 0.3 milligram of clonidine, or pick another class like captopril 6.25 milligram instead. Of course, every time you decide to give a dose, we need to check for contraindication again, even if you gave it 4 hours ago. Now, how about if we get called about a patient whose systolic blood pressure less than 160 and diastolic blood pressure less than 100, let's say 155 over 90. There is really no need to do anything here apart from adjusting his diet to low sodium diet and resuming his blood pressure medication or home blood pressure medications, if on any. You can leave it to the day team if you're covering the nights. There is no urgency about it. And it is not even a bad idea to have such patients just follow up with their doctors as an outpatient for further evaluation. The last thing, which is very important, make sure to explain to the nurse your plan. This will save you many phone calls and will reassure our nurses that we are not ignoring their concerns about our mutual patients. And of course, you will look like someone who knows his or her stuff. In the end, if you found this content helpful, make sure to give it a like and share it with your colleagues. Thanks for watching, and I'll see you next video.